Thanks very much, Tom, and thanks for that extensive introduction. I didn't realise you were going to read all that out about me, but thank you very much for that. And of course, thanks to Evidence Synthesis Ireland for the invitation to present on some work we did as part of the network. It's a pleasure to be here and to take part in these webinar series, of course. So as Tom said, I suppose he's covered much of sort of the aim of this session today, which is really to discuss some work that we did that was commissioned by the WHO last year, towards the end of last year, to inform interim guidelines that the WHO were developing for critical care and clinical care. What I think as Tom mentioned, the review work was on care bundles for improving outcomes in patients with COVID-19 or related conditions in intensive care. And it was commissioned as a rapid scoping review. So I suppose it was the focus of today is to talk through that work and how we went about it, and the activity, and particularly the collaborative activity that occurred within the work and the process, to ensure that we sort of met that deadline, but also met the quality that was needed, particularly given what the review was commissioned for. And I suppose then, because it was rapid, we were, if we think of scoping methodology in evidence synthesis and rapid review methodology, there are sort of differences there, and it was sort of balancing those differences, but also so the speed with the rapid, attending to scoping methodology, and also, excuse me, with that, meeting the needs of what the WHO needed, which was good quality evidence, particularly in the context of where we were with COVID-19 at the time. So that's really sort of the layout of what I'm going to run through today for you all. And in the context of, I suppose, where this guideline was positioned, it was an interim guideline, but it was coming in towards the end of the first year of COVID, and unfortunately we're still into our COVID phases, but it was not saying that we had a whole year by any means to do this review, far from it, but it was just to show you, I suppose, in the context of where the work was positioned in the timelines of the pandemic. And there had been interim guidelines produced by WHO earlier in the year, around May, I think they were. So this work was being commissioned to update those guidelines as a sort of living guideline, if you want, that the WHO were publishing. So that's sort of the context timeline wise with COVID. And of course, like many of this work, it all starts with an email. And anyone who knows the director of Evidence Synthesis Ireland, Declan Devan, he's not unfamiliar with late evening emails, and nor am I, having worked with him for many years. But the email came in on the 6th of October. So that was really the starting point of this work that was commissioned. The urgent email, and starts off with a sort of a sorry for the long-winded email, but are you interested in leading? And I thought to myself, right, this sounds quite intriguing. What's this all about? So the context really of that email was that the World Health the World Health Organization Health Emergency Team were looking for a series of rapid scoping reviews as part of their substantive update to their interim guidelines that they had produced earlier in 2020. The Guideline Steering Group had identified several new key clinical questions, and one of these questions was, do care bundles for patients with COVID-19 in ICU improve outcomes? So knowing that this was a WHO prioritised request, and sort of the are you interested in leading question, I thought, yes, of course, this is, very important work that is bound to be very impactful on clinical care. And as I mentioned, at a time when information for clinical care for patients with COVID-19 was particularly needed. So I was on board straight away. I thought, you know, this is important work to be you know, be involved in. So very happy to be involved, but of course, then came the clangor, as I would say, it's to be completed in 2 to 3 weeks. And I thought, oh my God, how is that possible, sort of thing. And not having done too many or been so involved in rapid reviews before, I thought that time frame is pretty tight, but having done lots and lots and lots of other reviews and knowing how long they can take, I thought, how is this going to be possible? So, but of course, like that, signed up to the challenge, and knowing that, you know, given that this was sort of the first week in October, knowing that we had to have all the work produced by the 2nd of December. So I think that was an important thing for us, knowing or for me in making this decision to, you know, lead this and be involved in this work, other than it being, you know, the importance of it, but also knowing the time frame from the outset, knowing that we had to have this work done for the 2nd of December. And that was quite an important thing in my decision making, because obviously we have other work and, you know, teaching and everything else that I do. I had to be able to commit to this from the start and know I could do it. So having that date from the outside, knowing when I had to have this work, was sort of a key decision maker, helping me make that decision. So it was good, but that's not to say the hands didn't go to the head and the mouth didn't drop to the floor thinking 2 to 3 weeks. Okay, let's see how we can get on here. So that was where sort of this work started and the challenge began. And the collaboration really began very rapidly after that. We, you know, within a day, we had the review team established, and Declan had reached out to colleagues with expertise in intensive care, which was so important to me, being a midwife by background. I'm not, you know, don't have that clinical expertise with ICU. So we had 2 wonderful experts on the team, Alistair Nicol and David Roach, established and agreed very quickly again within sort of the 24-hour time frame. So with this review, it was commissioned by the World Health Organization, but it was through Cochrane, the Cochrane collaboration. And via the Cochrane collaboration, they reached out to Evidence Synthesis Ireland and Declan, who then linked in with me. So that was sort of the pattern of the communication and who sort of interfaced with who, kind of thing, in terms of you know, various organizations. So Rachel Marshall, who's a senior editorial officer with Cochrane Central Executive, she was really the link between WHO and the review team, the World Health Organization and the review team. And she interfaced back to WHO to say the review team is established and, you know, ready to go, and the protocol planning began at that stage. So literally within 2 days, we had that work done in terms of setting up the review team and understanding, I suppose, the interface and who we were going to be linking with directly in the sort of Cochrane and WHO collaborations. So from those sort of first 24 or 48 hours, the only way to describe what happened after that was this flurry of emails that came hard and fast between the next, lots of them, between the next 2 to 3 days. But these emails and I suppose the interface with them were really important to, you know, for us as the review team to understand what was needed, to understand sort of where the WHO were coming from in terms of the review being commissioned as a scoping review, and just getting to know, I suppose, who are the main players that we were communicating with in each of the Cochrane and WHO organizations. So they were coming very quickly, hard and fast, early morning, late into the evening, but all good, because it set us on the right road in terms of producing this work. So from a collaborative activity point of view, I suppose that the first point I felt is that was the key point. And, I've learned from this in let's say, doing other reviews of this type or with large teams, that there was in each of what I call the organisations, be it Evidence Synthesis Ireland, the WHO, and Cochrane Central, there was a named person who was the key person that was communicating. So for myself as the review team lead and communicating with my review team, but I would have been leading the emails, if you want, to Rachel in Cochrane Central, who then linked in with the WHO directly. And even though many of us may have been included in those emails, what this meant is that lots of members of the different teams or the different organizations weren't emailing separately and individually, that everyone was copied in, but it was the main person, there was one person who was leading that communication. And that helped really, really, significantly. So we didn't lose information in transit, if you want, or that we didn't have lots of people and not sure what that person's role was in the different organizations emailing at the same time. So it was sort of the pathway of communication was from a named person that we all got to know, I think, through this process. And that worked really, really well. And it's something I'd take forward to, working with multiple teams on reviews in the future. So it was good to have that clear line of communication from the outset as well. A second really sort of key point in this collaborative activity that helped also with, I suppose, the quality of producing the work is, again, given the rapid timescales that we had to do this work in, was not reinventing the wheel. And I think that's where Cochrane Central came in, brilliantly for us, that they knew of other work in terms of a rapid scoping review that was in development around COVID content as well. And if there was any learning, that we shared it. And this is exactly what happened. And I think it's good to point this out, because even doing work similar like this in the future, or any type of reviews, that so many networks around the world even are, doing reviews, and it's getting to know those networks, including obviously Evidence Synthesis Ireland, that we can share learning between those networks and not reinvent the wheel. And for us, this was so helpful in the review process, because others had developed a template for a protocol for a rapid scoping review that they were, gratefully, we accepted their sharing those templates and use those templates. So we didn't have to start this process by, developing a template from scratch, particularly for the sort of scoping element of it in the context of a Cochrane review, because the scoping review was a new methodology for Cochrane at the time when we were doing this. So it was, some new territory that was being explored, and providing us with a template to work on with our for our review was really, really helpful. So excellent kind of collaboration there, and sort of offering of sharing and teams agreeing to share work that they had done. So that helped us quite a lot in this activity. So within a week, we had our first review team meeting, and we had our work plan established, and we had began work on the protocol. So it was all happening really, really fast. But it was happening quite, I have to say, I know this kind of, anyone who's done rapid reviews, they know they can be intense pieces of work, but it really felt at this stage like it was just happening really seamlessly. I think it was because the communication, everyone was committed to that communication, answering emails fairly rapidly after they received the emails, and then, making sort of available for meetings quite early in the process. And, that's part of the commitment, I think, that the review team gave in producing this work. So we sort of, I suppose, started the work proper within, a week or so of Declan's email of urgent, will you lead? So that all happened very seamlessly and very successfully, which was great. And I think that probably brings me on to another key element to the success of work and ensuring the work is done to a high quality is having the expertise, both topic and review expertise. And so Declan and myself were on the review from a methodology, sort of evidence synthesis perspective, from having done reviews before. But I can't say that I was, as I said, I wasn't an expert in rapid reviews, but I had a good understanding and grounding and of reviews in general, obviously. But what was really critical here was our clinical colleagues and having members of the review team that had the clinical expertise invaluable to this. And I think with any review that we ever do, we always know that those two sides to the review are critical to the success and quality of the review, having methods expertise and having clinical expertise. So we had Dr. David Roach, who was a clinician, and it was wonderful having David on, even though I'm sure it was really tough for him because he was, working in intensive care in the height of COVID and coming on board, and committed to this rapid process as well in producing evidence for this review. And then Professor Alistair Nicholl, who also a clinician and very busy at this time, agreed to come on board. But it was wonderful having that really senior coal face, if you want, expertise coming into a review such as this. And given the purpose of the review for clinical practice, these were clinicians who were involved in the review. So again, part of that success was the setup of the review team, without a doubt, and particularly our clinical colleagues being involved in it. So it sort of came as we moved through the review process, thinking about balancing, the rapid and scoping elements, given that we were producing a Cochrane review, but also evidence from that Cochrane review that was going to inform a clinical guideline, an international clinical guideline, where we had literally 3 weeks to do it. So, we needed to think about balancing all of this from the outset. And what helped was, again, using this template that others had shared with us that helped us really set out from the start in the protocol and helped us with the discussions via Cochrane to the WHO in terms of planning our protocol. Was it meeting their needs? And it was so important having that clarity on our PICO. And when the WHO commissioned the review, initially it was for patients with COVID-19, but with the clinical expertise in this and linking with the expertise clinically from the WHO side of things as well to Cochrane, we did expand the review population to include those with COVID-19 and related conditions, such as ARDS and viral pneumonia. And so from my understanding of this, and from what I was told, I say, because not being an intensivist, I wouldn't have too much understanding, but these other conditions were very similar to, in terms of symptomology and how patients might be to COVID-19. So expanding that way could provide maybe, particularly given the era it was and where research was coming out, it might have just built the evidence base, increased it, I suppose, for the needs of the clinical guidelines by expanding the review to include related conditions as well. So again, that's where that kind of communication and clinical input came into it. So we had very clear clarity around our PICO. We were looking at care bundles, and we were very firm in that the care bundle must have been based on the IHI definition, which was at least 3 or more evidence-informed practices, which were delivered collectively and consistently, rather than having to look for something that may be a care bundle or may not be a care bundle, we were rigidly very clear that we were going to stick with this definition. And then obviously our outcomes and stuff were established, and they would have came from the World Health Organization. These were the outcomes that they wanted to be looked at, I suppose, in this review process. So between that, that sort of good communication and collaborative activity, we established our people. That was, no doubt we were very clear on it. And it did mean through that communication, having expertise from the team, that we were able to, look at it in a wider context than just COVID. So once we had that sort of established, and it was then balancing, I suppose, the rapid process. So there's one element, as I mentioned, was the scoping process, but the other element to this work was the rapid process. And this is where we sort of looked at the rapid review methodology guidance and areas that we could consider without compromising quality so much, but also understanding that we have to produce this in 3 weeks and making some decisions around that where we could, maybe limit without compromising quality. So date restrictions were obviously one area that were considered. Language restrictions also were considered to, English language publications, particularly given the review team and maybe not, the time it could take to, like in a normal review where you've longer to do it, you can consider having non-English language publications translated or reaching out to, particularly with Cochrane authors and other review teams to assist with that type of work, but we didn't really have the time for that. So we considered language limitations. Also then placing emphasis on higher quality studies, such as systematic reviews or RCTs. Now, again, when we were thinking about this, because we needed to meet the scoping aspect of the review, we were not limiting to study design, but it was just, I suppose, in mapping and charting the information or the information that we might extract. We knew that we needed to, include systematic reviews and maybe place more emphasis on them, hoping that obviously the robustness that systematic reviews are done and RCTs, that they were providing quality information to the review as well. But I think the key thing here really in the search strategy and balancing the rapid process was involving an information retrieval specialist, and not just, like a specialist, but a specialist in the area and the topic as well. Many of us have worked with librarians when we do reviews, and Cochrane, obviously, if we're doing Cochrane reviews, there's information specialists assigned to Cochrane review groups. But again, there's been an area, particularly for me, that I wasn't familiar with. This played an important role in the success and quality of this review. So again, through collaboration with Cochrane Central, they secured additional support for the team through the information specialists at the Cochrane Anesthesia Critical and Emergency Care Group, who was Jan Vent, and she was fantastic in developing our search strategy for us and working so closely in doing that in a very short space of time. So again, that was another way we didn't have to do that as a review team, secure this. It was Cochrane offering that support for the review itself, which was amazing. So what also helped with the search methods and the expertise when we had Jan was also then, again, bringing in the clinical expertise who are able to review the search terms and things. But at the outset, there was also giving the need for peer review that would happen with the protocol. Cochrane had established an independent peer reviewer for the search strategy alone, which was Robin Featherstone, from the outset agreed. So again, I think part of these processes when reviews are commissioned like this is having all of this in place so early on in the process, like within, your 24, 48 hours, having people committed to tasks that would ensure the quality of the work that was being done. And also then, because we had been quite strict on our care bundle definition, and what we were considering was a care bundle rather than maybe something before that IHI definition could be considered a care bundle, but not sure. We stuck with searching from 2000 onwards, because the IHI definition came in 2001. So we felt we were, fairly on track by limiting our search from that date onwards. And what was also helpful then was, picking our main databases, but also the COVID registers that were available, given that this was a review for the COVID era and COVID content. So it was being fairly clear around our search methods and having a team purely for the search, because as I think we all know, if our search strategy isn't up to scratch in a systematic review or any type of review, we're sort of on a downward slope or a disadvantage from there on in. So we understood from the outset how important the search was going to be, and all the players were in place to ensure that that search would be, the strategy would be of good, high quality. So that was our search methods, and some of the other limitations then that we needed to consider without compromising quality, but at the same time being able to achieve what we needed to achieve in our 3-week time frame, was what limitations we might apply to our additional sources. And what we decided was to not look at the grey literature, and thinking that, again, thinking back to the purpose of a review, which we had to keep, what I was reminding myself of the whole time, this is to inform a clinical guideline. We steered away from searching grey literature, which can be, time consuming and intensive, and stuck with that sort of the published, but also studies that were in press, and then looking at the reference list of included studies. So we limited our searching of additional sources to those key areas. And I think our studies in press was important because, again, you will all know, a lot of studies, preprints and that kind of thing, were appearing during the pandemic and still are. So we felt without including that aspect, we could miss particularly COVID-related studies, and not so much the related conditions. So that was key for us. So these were just some of the decisions as a team that we were making. But with this sort of template, it guided us in making those decisions, and helped us make them, which could then be peer reviewed by reviewers from Cochrane, but also, and for the quality, to ensure we were doing sufficient in the context of rapid as well. So our approach to screening, and again, this was sort of the rapid rather than the scoping end of this work, was to look at, how we were going to manage our screening and our data extraction activity as part of the review. So with the screening, what we agreed to do was a second reviewer would check 20%. So one reviewer would screen all, obviously, and a second reviewer would screen 20% of the excluded records. And if we had agreement that was greater than 80%, we would be satisfied with that. But if the second reviewer, if it ended that we had agreement that was less than 80%, then the second reviewer would screen all abstracts. So, and the important thing, I think, is we had David, like, as part of the review team, having the clinical expertise was the dual screener for these. So it was important to have that balance, rather than like myself and Declan doing it or something, who are two methodologists. So it was important to have that balance. And thankfully, we had very good agreement. We were well up on 98% or something when this process was done. So that was very reassuring, I suppose, for me as the initial screener. And this sort of activity is where we took our agreement of 80%, it is something that comes out of Amster 2 guidelines as well, when you're not in a position for both, ideally, for both people to screen all. So that worked really well in our timeframes, and the reassurance it gave us that I wasn't in particular screening out records that may have been eligible. So that was reassuring for the process. And obviously we had our third reviewer established there in case we did have any discrepancies that needed resolving. And for our abstracts, again, normally, you know, in a review process, we might have expanded on the inclusion of abstracts in conference proceedings. But what we decided here is only to include if clearly eligible and have usable data, because the time frame to maybe go back to authors, seek maybe more data or more information, we just didn't have it in this process. So we were quite happy to include if any identified that had clearly usable data. So they were just sort of some of the decisions around our screening process in making this work for us in the time frame that we had. And then there was, you know, further merging our rapid and scoping methods. And for those familiar with scoping review methodology, one of the things that generally doesn't happen unless there's a rationale for it, because you're sort of scoping the extent of the literature, is that a risk of bias or quality assessment of included studies is not required. So that was a real help, I think, in helping with timeframes, that we didn't have to spend so much time, you know, doing a risk of bias assessment. And similarly with the data extraction methods, we applied the same approach as we did with the screening of abstracts, where a second reviewer would check the 20%, and if there wasn't more than 80% agreement, we would revert to both reviewers extracting the data. But thankfully, again, we had good success with that, again, up on nearly 100% or 99%. It was very close to the 100. And again, that was during, and I think some of that, it was because of having sort of our clear PICO and exactly what we needed to extract from the records that were included in a review, having that clarity from the outset. So when it came to presenting the data, and this was one of the key learning areas for me in doing a commissioned review like this. So it was commissioned as a rapid scoping review done in a rapid time frame. But given, I suppose, what it was commissioned for, which is a guideline, you know, the WHO probably were looking for some effectiveness data as well, although it wasn't commissioned as an effectiveness review. And that only became apparent for me a little bit later in the process, nearly as we had the review completed and had a full first draft sent to Cochrane. And it was a learning sense in that we need to be clear from the outset what's being looked for. So I was very clear, and as a review team and Cochrane, we were very clear that it was a scoping review. So we were scoping the extent of the evidence, what types of studies were out there. But it became clear then, I suppose, and thinking back, I suppose we could have thought a little bit more about this at the beginning, that given that it wasn't forming a guideline, you know, some effectiveness data would obviously be useful there, but it wasn't commissioned like that. So I'll talk a bit on how we managed that in the end. But it was a learning point. While we felt very clear, there's always these little things that can come up in these processes that maybe need that discussion, that would have been helpful to discuss at the start. But that was the only little challenge, I think, that emerged during our rapid scoping process, which I'll talk about in a minute. So in terms of the timelines and the collaborative quality activity, if you want, we had our protocol submitted by the 22nd of October. And already at that stage, the Cochrane central team through Rachel had set up a panel of reviewers who were ready to go and committed to reviewing our protocol in a very quick time frame. And I mean, it was amazing. We got our feedback, you know, in 5 days on our protocol, which helped us move the process along. So we all know when it comes to reviewing even protocols and papers, it can be, you know, weeks, if not months, sometimes before we get feedback. So this was critical, I think, in the success of this, that these reviewers were established, were in place, were ready to go, and responded very quickly to our protocol submission. And they had the expertise then across the clinical and methodological spheres. And as I said, the search strategy was even reviewed before submitting the full protocol. We'd had some, between Jan and Robin, some, you know, to and fro about the search strategy. So it all helped so significantly in progressing the review for the WHO within the timelines that they had, you know, and we had, basically. So once our protocol submitted, again, I think that this is a key point, is agreeing timelines. So we knew from the outset that we had 2 to 3 weeks, but 2 to 3 weeks for, you know, can when you're doing a review, can fly by very quickly. And particularly, as I said, you know, David and Alistair were working clinically, and Declan and I had obviously other work. So what was established then with Cochrane, the WHO, and ourselves was clear dates for tasks. And again, this is, you know, it's always good, in my opinion, to put timelines and things, but these were, you know, we had to work to these timelines. We were very clear from the start, and it enabled us to say, yes, we're committing to those timelines, or have that discussion as to those timelines are impossible, we need a couple more days, or, you know, we knew we weren't going to have weeks. But so we had a table established like this that was circulated for the work ahead once the protocol was submitted and peer reviewed. So when it came to then moving on to the full review, again, what was really helpful, and what I'd have done in the past, but, you know, it's just to maybe point out that this is something we should all be doing together as networks, is reaching out to each other with for help on reviews, and particularly if they're rapid reviews. So often in the past, if I've got full texts that, you know, are not available on my library, I go around colleagues, or I go to the librarian and get some help in sourcing them. But you know, and we do reach out, but for us, we reached back into Cochrane to help, because with their extensive network and libraries, and within sort of, I think it was 24 hours, we had 9 full texts that we couldn't access, that were sent, the Cochrane team accessed for us and sent back. And that was so helpful, because that can, you know, while you're waiting on full text, it just delays moving on to the next stage of a process, in a review process, in a way. So again, this is part again of the network and the collaborative activity that happened in this work that made it, you know, that helped it be successful in the time frame that we had. So again, it's just a kind of a key point to, you know, to always think about reaching out, that, you know, regardless, I suppose, if it's this or any other type of review one is doing. So in progressing the review, and this is where, while we have the collaborative activity and the clear lines of communication, we also had commitment. And knowing from the outset, as I mentioned, how long we had to do this review, but also I think as a review team, and this is us ourselves, where all 4 of us were committed to this activity and knew that it would involve some late evening meetings, and were, you know, the kind of non-family or the family non-friendly hours, knew that we were probably going to have to give up some evenings to get this work done, and also committing to, when drafts were being circulated, that each team member would comment on that draft, you know, within reasonable timeframes, which is like 2 to 3 days, basically. I don't know if you call that reasonable, but in the context of this, that was our reasonable timeframes. And we had 21 studies that were eligible and included in the review. So a little bit of work to get through. But I think, you know, everyone was on board to commit to that type of activity for the couple of weeks that, given the importance of the work that was being done. And this is back to then what I mentioned earlier about balancing our scoping methodology, and given that this was being published as a Cochrane Rapid Scoping review, but also the needs of the clinical guideline group in terms of effectiveness. So what we did to overcome and manage that, and as I said, the kind of effectiveness bit came out a bit later in the process, and the need for data and results. So what we did to manage that was, for the Cochrane review itself, we stuck to the scoping methodology in terms of charting, you know, the extent of the literature and the type of the literature that we had identified on care bundles. And, you know, when we did that by patient condition and study design was one way that we charted. And then we also charted in the review itself on the outcomes that were being reported across the studies. But to address the effectiveness thing and the need for the WHO to have results data, if you want, we set up the project in the Open Science Framework platform, which is an open access platform that you can set up any project in there and add files to it, and that for anyone who isn't familiar with it. We set up our project in there, and that's where we were able to provide the additional information outside the scoping review itself. So, for example, we provided an additional file, really detailed file on the description of the care bundle. So what exactly was included in all the care bundles that were described in each of the studies. So that was, you know, sort of 8 pages long of text data that wasn't necessarily needed in the scoping review publication itself, but a link to it for those who are interested in in-depthly interrogating or looking at the care bundles was made available. And this file was made available to the WHO as an additional file also. And the other way then was we tabulated the results data from all the included studies by condition, and what outcomes were measured and what the results of those outcomes were, and provided that to the World Health Organization along with the review itself for informing their clinical guidelines. And I suppose what this helped also sort of show was that, you know, the like you do scoping reviews, one of the aims can be as a precursor to a systematic review. So it gave us that extent of the studies that were being done, what outcomes were being measured, but also to provide the clinical guideline group with the data and results for those outcomes, so they could use that to inform their guideline as well. So it was just balancing the scoping methodology with what the WHO needed for their guideline, and that's how we overcame this. So we had a review submitted on the 17th of November, and with the additional files, as I mentioned there, and that it was actually the 18th of November we submitted, and we submitted the 17th to Cochrane, and Cochrane had their quality, had our review quality assured within 24 hours, and had submitted to the WHO by the 18th. So we're only 2 days late from our agreed timelines. I think we did all right. It wasn't too bad. It was intense, but we got there. And that was the importance of having those deadlines and dates from the very start. We worked towards them and were committed to working towards them, and sort of made the work happen while not compromising the quality in terms of having the Cochrane network as well, quality assuring our work, and the peer reviewers that looked at it as well. So we got there. But you know, what I could see then, when through some discussions that were sort of happening at that stage, was, you know, sort of potential next steps if the WHO did actually require a full systematic review, which would be an effectiveness review with a meta-analysis and all of that kind of work. But as it turned out, they had all of the information that we had provided with the additional files, and the Cochrane review itself fed into their guidelines, which were then published in January. And it was really, really good, I think, to see as a team, and you know, the intensity of the work. And when I say intense, it felt intense, but not overly intense, because everything with the good collaborative activity, it just seemed to work very smoothly. We got answers to questions very quickly. We had things turned around very quickly. So it allowed us, you know, it wasn't burning the midnight oil for 3 weeks solid. It wasn't at all. It was doing some late evening work and some early morning work, but it sort of flowed very seamlessly, really, because of the commitment and network of people involved. So it was really good to see the recommendation for the use of existing care bundles in that clinical guidelines at a time when COVID was, you know, really at its height, and to be a part of this kind of work and the importance of it. So to sum up, really, I suppose I'm going to sum up this work and this activity, what I've called the 5 C's, and I've mentioned most of all of them, really, as I've went through my slides there. But you know, I think it's in doing a rapid review that's commissioned for something like COVID, or something as clinically important as that, and the reason it's been I suppose commissioned is to inform, you know, that COVID front face clinical care, is to have clarity at the outset. So have clarity on what's needed, what are the timeframes, what are the dates, you know, what's your PICO, having that really clear at the start. And I said that worked really well for us. The only little bit was around the effectiveness bit versus the scoping bit, and we managed that, we got over that. So having that at the start, having the commitment at the start, there is no doubt, and knowing that you've 3 weeks to do this, and knowing if you can't commit, don't sign up for something like this unless, you know, you're able to commit and it's reasonable for you to commit. And then when you do, you know, it is then, I suppose, number 5 there, the continuation. It's continuing that commitment for the duration of the project. Collaboration is key, and I have to say it was the collaborative activity in this process was amazing. We had so much help from Cochrane Central, and then that link with WHO as well, where they were liaising and interfacing behind the scenes a lot for us, and getting questions answered helped us so much. And then the clear lines of communication, you know, not having, because there was lots of people involved. There was 4 of us on the team. There was probably, you know, 4 people in Cochrane that were on emails, and there was 4 or 5 people in the WHO on emails as well. But the, you know, the clear lines of communication is one person being the spokesperson as such, rather than loads of emails flying back and forth and getting lost in translation. And for me, that's something, you know, I think would forever is important when doing reviews. And then, as I said, continuation. So it's committing to it, but then maintaining that commitment with strong cups of coffee if needed, or you know, a fruit boost in the morning, or something, if it's an early morning bit. But it's just, you know, maintaining the stamina for the couple of weeks, and not losing faith, considering how important the end product to the work is. So that's how I'll sum up, and I'm probably up on my time now, nearly there. So it's just to say thanks very much for listening. I hope you enjoyed it. It was very much just sharing my experience and our team's experience with you, but some of the lessons, you know, we learned that hopefully might be helpful for you along the way as well. Thanks very much.